My name is Colin Cade, and I'm an associate professor of emergency medicine at Ohio State University. And I know it says in the brochure there that I'm from California, and that would make me cooler for sure, but I am actually from Ohio. And just a couple of quick disclosures. I have done some clinical insight work with Portola Pharmaceuticals and with Diagnostic Astago. And probably the most important disclosure I have to tell you about is I actually work in the Abercrombie and Fitch Emergency Department at the Wexner Medical Center at The Ohio State University. And I wish you could make that stuff up, but that is really true, and that is a real picture from our emergency department. And I know I don't fit the clothing builds, but I'm kind of working on it. They have a larger size range coming out for me in the near future. So I got interested in this kind of stuff with coagulation and anticoagulation reversal and this stuff because for a brief period of time in my life, I was married to a hem-onc doctor. And there was always a little bit of medical rivalry in the family. And you notice that happens if you have two doctors, especially if they're from different specialties. And we had emergency medicine versus hem-onc, and that's not a very hard rivalry to figure out who's the winner of, right? We're a heck of a lot cooler, but I did notice something. When you tell a story in emergency medicine, the people who are listening to the story, they might throw up. It's possible, but they'll at least understand the story and understand what you're talking about. When you hear a hem-onc doctor talk to another hem-onc doctor, it's like they're talking in a completely different language. And I had to get used to this a little bit. I heard her talking one day to one of her colleagues about a patient of theirs who had NHL, who then got RCHOP, followed by Rice, and then got TBI for a BMT. He dropped his H&H, got some PRBCs, developed trolley, ended up in the BMT ICU with TTP, and then got plexed. And after I listened to all this stuff, I thought it was like watching my daughter text. All I could think of was OMG, IDK, WTF she's talking about. But I'm pretty sure the patient's going to DIE by the time this is all over. So you got to learn this language. It's a complicated language, and you can get it, especially if you take out the parts that sound crazy and get to the most important fundamental concepts of coagulation and anticoagulation. If you can break it down to the level that we need to understand, all of the rest of the stuff with this, it can be easily derived just by understanding a few things. So the goals today are to review hemostasis and the balance between coagulation and anticoagulation in a way that applies to our world, and not to the way it applies to a PhD nerd who's really studying the intimate details of this stuff. We want to understand this at a basic level and derive the details, and we want to discuss some strategies to reverse anticoagulation and antiplatelet drugs. So one of the disclaimers we're talking about is when we're reversing some of these agents, we are talking about big-time emergency bleeding. We are not talking about somebody who has an elevated INR or who has a little bit of easily controlled nosebleed, because the agents we're going to be talking about for reversal have potential to create some significant complications for our patients if we use them indiscriminately, and also our pharmacy will not pay for that stuff if we're giving it without a good indication. So there's a lot of in vivo and in vitro, a lot of in vitro and ex vivo data looking at surrogate markers and lab values and some case series, but there are not really well-designed placebo-controlled double-blinded studies. There are a lot of studies out there, but they're not comparing necessarily exactly what we want to see, like a reversal agent to no reversal agent. They're comparing usually to some other standard. So I just have to say a lot of this stuff is not FDA approved either. So just so you understand what we're talking about, some of it is and some of it isn't. This is just a little idea, just to give you an idea of where our anticoagulation is going these days. Warfarin still makes up a huge component of this, and dabigatran is actually in a slightly smaller position than before, and there's a new one out there that should be sitting next to rivaroxaban. It's called apixaban. Rivaroxaban and apixaban have picked up quite a bit, and warfarin is slowly coming down a little bit in its popularity and in its causing of major bleeding events. So warfarin is still probably our biggest difficulty that we see in the emergency department. But stay tuned. Now that there are some new reversal agents that are out there, we're going to see an increased use of some of these other agents like dabigatran, rivaroxaban, apixaban, edoxaban. So it's something that's that's right on our doorstep. What do we need to know about coagulation? First of all, it's a very important balance between bleeding to death and clotting solid. On one side, we've got proteins and antithrombins and tissue factor pathway inhibitors and fibrinolysis and prostacyclines. And on the other half, we have the hypercoagulable state. That's Virchow. And Tissue injury, hypercoagulable state, and stasis. These are the things that are going to tip us in the opposite direction. We have to be able to balance one direction to the other and be very cautious about how we tip this balance without creating either too much clotting or too much bleeding. This is too terrifying to show people, especially near Halloween, because we have clowns for Halloween. Okay, that's scary enough. We don't need things like this. So we're going to break this down into something a little bit more straightforward. I want you to think of hemostasis as two parts. Primary hemostasis, which is platelet aggregation, followed by secondary hemostasis, which is the coagulation cascade. These are completely independent. They're measured independently, and they have different markers and different agents that affect them. So just to talk about primary hemostasis, the first thing you see is injury to the endothelium. And when this happens, you expose the underlying collagen, which then allows von Willebrand's factor to attach and subsequently cause platelets to attach to the surface. This is primary hemostasis. This is the platelet plug, and it causes the initial blockage of bleeding. This is not a very solid clot at this point. We need to be able to strengthen this with fibrin, so we get to secondary hemostasis in a couple seconds here. When this platelet attaches, it elaborates a lot of different things that cause more platelets to show up at the scene. Thromboxane A2, serotonin, ADP, magic platelet, fairy dust, and then all these platelets arrive at the scene and begin to increase the size of this plug. Now, what's the role of fibrin? Fibrin is the cross-linking strands that bind the platelets together that create a solid clot. And there are two pathways that we look at that get us to what's called the common pathway that leads to the generation of fibrin. And I'm going to break this down so easily that you're never going to forget this again in your life. I know you learned it once or twice in your career, but I'm going to show you why this is so straightforward. This is the complicated version of the pathways. Contact activation pathway. We used to call this the intrinsic pathway. We had exposure of collagen followed by a sequential activation of factors. Why is this important to think about? 8 and 9 play a role clinically for us in hemophilia. There are no diseases that we care about from some of these other factors that we're going to even be able to recognize or be able to manage. So on that side of the cascade, there's only 8 and 9 that really matter. They activate 10 as part of the common pathway. And why is 10 important? Because we have anti-10 drugs. That's a big portion of what we're going to be talking about later. The other side of the pathway, called used to be called the extrinsic pathway, now called the tissue factor pathway, is activated by factor 7, which also has the ability to activate factor 10. And what happens here, to get to your final product, factor 10 combines with 5, catalyzes prothrombin to thrombin, fibrinogen to fibrin, and we make a clot. This is still too complicated with this pathway. Let's break this down into other numbers that are easier to remember. Why was 10 afraid of 7? Because 7, 8, 9. That's the top of the pathway. And how did 7 kill 10? He brought his friend along and divided in half, or divided by 5. That leaves us with 2 at the bottom. If you remember this much of the cascade, this is all you really need to know. The biggest portion of thrombin generation occurs with factor 7. This is the important part. It is the big deal here, and this is the one that happens first and generates the most thrombin, followed eventually by the opposite side of the pathway, which is more involved in inflammation than in coagulation. And eventually where we end up here is our goal of binding the platelets together. If you just remember 2, 7, 9, 10, you're done, because that's where all of our anticoagulants are acting at this point. There are other diseases like prothrombin gene mutation that's a procoagulant thing, or antithrombin 3 deficiencies, or other things like that. But for this purpose, the easiest way to remember this is 2, 7, 9, 10. So let's talk a little bit about how we can reverse anticoagulation, how we get past this idea of FFP for warfarin as being our only reversal agent that we have. First of all, where does the name warfarin come from? Anyone know? Yeah, people got it out there. It's Wisconsin Alumni Research Foundation plus the end of coumarin. And this brings us the word warfarin. Rat poison. So where does this work in the cascade? Warfarin inhibits the production of active forms of factors 2, 7, 9, and 10, so they kind of disappear out of our cascade here. And when this happens, we've got multiple points in the cascade that are being hit. So in order to solve this problem, we have to do a couple of different things. First and foremost, we have to create the regeneration of these factors, and second of all, we've got to do it very quickly by supplying additional factors back. So there's two parts, immediate reversal and sustained reversal. For the immediate reversal, we'll talk about a few different agents, but we'll start out with FFP. Every ml of FFP you give somebody contains 1 unit of every coagulation factor. contains a little bit of fibrinogen, and the volume is about 250 mLs per bag, and it costs about $250 a unit. By the time you get the acquisition cost, the delivery cost, the freezing cost, the thawing cost, the pharmacy processing cost, and the delivery to the patient, it's somewhere around $1,000 for a dose of 4 units, which is where I'm going to make a recommendation that you start. So, the dose that we typically think of is 10 to 15 mLs per kilo, but I'll tell you that you really want to start out at 4 units minimum for somebody who has clinically relevant bleeding that you have to intervene on, and I'll tell you why. Part of the problem that you run into is understanding what is the best INR that you can possibly obtain. And what is it, so in order to come up with the best INR that you can get by giving someone FFP, you might ask yourself the question, what is the INR of FFP? Anyone know? It's 1.5. So I can't get you easily to 1.5 by giving you something that has a level of 1.5 if you start out at 3. So what you'll see, if someone has a very high INR, in the first few units of FFP you give them will bring them down rapidly to close to 2 or 2.2, but to get them the rest of the way so that they are no longer bleeding, you really have to sometimes add a lot more in the end. That's why I'm recommending you just forget about 2 units and start with 4. Your consultant orders 2 with clinically relevant bleeding, change the order. You're done. You've got to think of something else. Now there's a new set of drugs out there, and new, I say, to the United States because there are still some places that don't stock them, but when I gave this talk before, the people from Europe are like, what are you talking about, FFP? We've been using PCC since the 80s. And a PCC is a prothrombin complex concentrate, and the prothrombin complex is the 2,7,9,10. And there are basically two versions of this around. These are basically non-activated clotting factors, so they have to be activated by, enzymatically by your system for them to work. And there's 2 types, a 3-factor and a 4-factor PCC, or prothrombin complex concentrate. The 3-factor PCC is really a 4-factor PCC, but it has such a tiny amount of factor 7 in it that we consider it to be negligible. So it's really that there are only 3 factors, 2, 9, and 10, that are really giving us any kick there. The product that's available in the United States that supplies us is called Profile 9, and this is what we've been using at OSU for many years. There's now a 4-factor PCC that's available in the United States. It used to be available in Europe under the name Bariplex. Well, actually, it still is under the name Bariplex there. They rebranded the name when it was brought to the United States. This is a 4-factor PCC that contains adequate amounts of factor 7. And it also has a bonus. We don't know if this means anything or not, but they also have little protein C and protein S to balance you out so that you don't over-reverse the patient. Whether that has any clinical relevance whatsoever has not been proven. So, what about these prothrombin complex concentrates? How much do they cost? Are they ridiculously expensive? Depends. Profile 9, our pharmacy cost is about 59 cents a unit. Figure an 80-kilo person times a full reversal dose of 50 units per kilo. That's about $2,300 to be able to reverse somebody at the highest level of the dose. You look at a product like Kcentra, the new one that's out there, it's probably about twice that, maybe a little more than twice that. So these things are not inexpensive, and they're not something that you would say, I'm just going to randomly give these reversal agents to somebody who does not have clinically relevant bleeding but just has an elevated INR. You have to have a reason why you want to do this in order for this to make a lot of sense. All of these things are dosed based on their factor 9 concentrations. And so when you order it, the pharmacy will figure this out for you. You'll say it's 50 units per kilo. What you're doing is the units you're talking about is the factor 9 because they're generally standardized along their factor 9 content. No matter which product you use, whether it's European or American, they're all standardized along that way. So just to give you an idea here, 4 units of FFP has about 1,000 units of each one of our factors. Profile 9 has 4,000, 6,000, 2,500, and only 1,400 of factor 7. Kcentra is pretty close in some of the numbers there, a little more factor 10, and it also has about twice the amount of factor 7 in it. Again, the cost is about twice as much. So it depends on which one your hospital formulary has decided it's going to carry. Who has PCCs in their institution right now? Use them pretty regularly for your warfarin bleeds? Yeah, when it's indicated. And what you're basically doing is you're bombing the coagulation cascade by throwing in a bunch of factors and replacing the stuff that has been missing. So the pros of PCC, it's very fast. By the time you're done with the infusion, your INR will be pretty close to normal. That's interesting. It's not crazy expensive, but it is not cheap. Let's put it that way. It corrects lab values, and as far as we can tell by the limited clinical studies that are out there, it does improve the amount of bleeding as witnessed by people who are doing the surgical procedures what they'll tell you is we're giving less blood to the patients when we give them PCCs. Is this a substantial improvement in life-saving over FFP? The answer is not certain. Probably that question has not been completely answered yet. But if you think about the person with a ruptured AAA who's going to the operating room in the next 10 minutes, giving them the reversal agent that you can reconstitute and push and have its effect completely there within 10 minutes makes a little bit more sense than thawing FFP and waiting an hour or an hour and a half to reverse them so they're able to go to the operating room. Because a lot of anesthesiology guys and a lot of surgeons don't want to go to the OR with someone who's profoundly anticoagulated. So the cons. Disease transmission is possible. This is a boiled down, basically this is a boiled down factor product where you get rid of, we basically take the FFP and concentrate the stuff at the bottom. So it's not viral free, but it is treated. There's a small thrombogenic risk because you are throwing a lot of clotting factors at somebody who, if you remember, was on an anticoagulant for a reason. If it was for AFib, you have less to worry about. If it was because they have a prothrombin gene mutation and factor V Leiden, you do have a slightly increased risk of creating a procoagulant state in that patient. So balance your risks and benefits when you're going to use something that has a lot of potent reversal capabilities. So the studies that have looked at PCC, a lot of European studies included, 460 patients, 1.5% had events that were both arterial and venous clots. It's hard to say when you have someone in an ICU from a substantial bleed if that clot is because they're in the ICU and immobile or because they received the PCC, but you shouldn't be seeing a lot of arterial clots, and occasionally that happens. And what you don't want to do is this to your patient, because this is a great way to ruin someone's day with a very large saddle embolus. I always used to think a blood clot in the lung was this little tiny cute little round thing. Then I actually saw one and I said, oh, okay, I get it. It's a cast of your entire venous system. This makes more sense now. Safety of PCCs, one other study showed 2 out of 215 cases where people had inappropriate thrombosis. Not zero, not dramatic. Dosing. There are 3 regimens that have been pushed out there. A random dose of 25 to 50 units per kilo, depending on what you want to do. A dose that's INR based. An INR of 2 to 4 gets 25 units per kilo, 4 to 6 gets 35, and greater than 6 gets 50 units per kilo. And then there was an absolute dosing that was studied at one point in time. If the INR is less than 5, you give 500. If it was greater than 5, you give 1,000. You know what? I think most protocols that I've seen and most that I've been involved in the process of researching to write will talk about an INR-based dose like this. And this is probably where we should be at when we're talking about how to dose these medications, because it makes a little bit of sense that we're not blasting everybody with the high end of the dose or underdosing. We're kind of targeting what our INR is actually at. What about this? This was really popular a number of years ago, Novo 7. Factor VII recombinant. This is interesting because it very much can activate the clotting cascade and make bleeding stop in some cases. But the interesting part is it didn't work really well at all in patients who had warfarin bleeding. In fact, in the rat models and other animal models, the bleeding wasn't significantly slowed down at all by comparison to other agents. And you think about the cost of this. 1 milligram vial, 1,000 mics times $1.10 per mic, $1,100. 90 mics per kilo, that's $6,900 for one dose. Now the dose lasts a very short period of time, so you have to give it every Q3 to 6 hours, and you may need as much as 4 additional doses, so you're talking about $55,000 to treat somebody. Now this is all relative, right? Money is relative in medicine. So I'm going to give you the extreme ends of the units for relativity, just to keep you awake here. That's 0.4 Porsche Carrera 911 GT3 RS units. And 0.00011 stealth bomber units. So it all depends how you look at it. The only problem with it is the conclusions for this, it's very expensive. The thrombogenic risk has been significantly higher than PCCs, and the bottom line was it's no longer written into the guidelines for people to be using, but you will have neurosurgeons or other people who will say give them factor VII. The answer to this is that is no longer in anybody's guideline to reverse warfarin bleeding. Just not acceptable at this point. There's another agent that we're going to talk about because it has utility in reversing some of the newer agents prior to the newer anticoagulation reversal drugs coming into existence. And this is something called FIBA, Factor VIII Inhibitor Bypassing Activity. Anyone know what FIBA is? You guys use it? Where you would see FIBA used is in a hemophiliac who is receiving Factor VIII replacement. Then they develop antibodies to Factor VIII. So you give them Factor VIII inhibitor bypassing activity, which is basically 2, 7, 9, and 10, same as PCC, except they are all enzymatically activated. So these guys are running around and buzzing and waiting to cause some trouble. Now, does that mean that they are substantially more dangerous necessarily than a PCC would be in a person? The data seems to show that they're more thrombogenic for simple warfarin bleeding, but they do have an indication with some of the newer anticoagulants. So, yeah, it worked on warfarin very well, but there was a slightly increased risk of someone developing a complication, and it's a little bit more expensive than even the most expensive PCCs that we have. And chances are your institution will not have FEBA directly on formulary unless your guidelines include it to reverse some of the newer anticoagulant agents, or you're a center that treats hemophiliacs, in which case you will have this stuff available. But in order to get it on your guidelines, on your formulary, you'd have to probably go through a big pharmacy process if it's not already in your system. But we'll talk about how it's used later. Now, when we talk about reversal of Coumadin, we have to talk about a sustained reversal, because we can give you factors that you don't have for a while, but eventually your body needs to start generating factors on its own. So you do that by giving them the substrate to do that, which is vitamin K. So you can regenerate active forms of 2, 7, 9, and 10. There is no more sub-Q dosing of vitamin K in any guideline. It's either IV or oral. If they're bleeding and it's a life-threatening bleed, or somebody needs to be reversed quickly, you give them the IV version at the 10 milligram dose. And what happens is that dose starts its effect in 2 hours. It doesn't finish for 24 hours, but it starts early. Sub-Q dosing is erratically absorbed. And what about anaphylaxis from IV vitamin K? It happens, but it doesn't happen often enough to preclude using it in the setting of a really significantly bleeding patient. In the patient who has non-life-threatening elevated INR without significant bleed, it can be given orally in small doses, and it's very effective. So let's talk a little bit about heparin and low molecular heparin and some of the direct inhibitors, so we understand how these things are working. Heparin and low molecular heparin. Heparin is this big, giant, ugly molecule. If you cut it into little pieces, those are called low molecular heparins, and they have a similar effect, although they have more specificity depending on the particular low molecular heparin for its activity against factor 10 than against factor 2. So let's see how this works. It requires antithrombin. That's why these are indirect inhibitors. And what happens is they'll bind factor 10 and factor 2, and heparin, garden variety heparin, does this in about a 1-to-1 ratio. When you're talking about low molecular weight heparins, it's a different answer. Now, because, and I'll tell you this is part of the way the assay works, because there is a significant amount of effect on factor 2, a PTT can be useful for you, because the reagents that are used during the process of measuring your PTT depend upon the activity of factor 2. Just keep that in the back of your mind here. So PTT can be used to measure heparin effect. That changes when we talk about low molecular weight heparins. So here's the low molecular weight heparin binding to antithrombin. This is enoxaparin, dalteparin, and tinzaparin. And they bind, but about a significant higher portion of the binding occurs to factor 10 than to factor 2. And in fact, the ratio can be 2-to-1 with the first generation low molecular weight heparins, and as high as 5-to-1 with the higher generation and newer low molecular weight heparins. So you can no longer measure a PTT to help us understand how well this person's anticoagulated. If you need to know, and you are definitely on a need-to-know basis, you can look for anti-10A activity. And why do I say you're on a need-to-know basis and you probably don't? Because most of the time, people are going to be within the therapeutic range, and their anti-10 activity is going to be adequate. The people you run into trouble with are really big people for whom you've underdosed their heparin, their low molecular heparin, or really small people, or people who are clotting despite being on a low molecular weight heparin. You want to find out if that's having the desired effect. So this is going to be an inpatient thing, but it can come up as a board question, or your internist may say, can you order a 10A level, anti-10A level? You say yes, but I'm not going to be able to use it clinically because it's not going to come back for me to see in my emergency department in most cases. That may change when knowing anti-10A levels in real time could change your management. We'll come back to that in a little while. So so our reversal agent is protamine. Where does protamine originally come from? Yeah, salmon and whale sperm. I don't know how someone figured that out, but that is one sick dude. So it binds to and inactivates heparin, 1 milligram per 100 units of heparin, but it's easy to remember because a fully heparinized patient just requires the max dose of about 50 units. 50 milligrams. The reason why it becomes a problem if you go on too high of a dose of protamine is that it has an anticoagulant effect itself by affecting factor 5. So you reverse your heparin with 50 milligrams, you keep giving more, and what ends up happening is you start to get an anticoagulant effect by itself. So there is a limit on how much you can give. You are almost never going to reverse heparin in the emergency department unless you started it on a PE patient and they go, oh my God, my aneurysm blew. Then yeah, you might want to do that. But most of the time, protamine is used in the operating rooms when they want to reverse somebody after keeping them anticoagulated for a portion of a procedure. You might consider using it in a low molecular weight heparin case, although we do have an upcoming answer to that problem that's a lot better than using protamine. So here's the deal with protamine and low molecular weight heparin. It has about a 60% blockage of factor 10, anti-factor 10 activity, and about a 90% blockage of the anti-2 effect. So overall, we say that it roughly has about a 65% on average effect on the bleeding associated with low molecular weight heparin. So you're not going to get complete reversal, but it may be a reasonable thing to consider in some cases. Basically, you look up the dose rather than memorizing it from here, because I would have to look it up every time too. With low molecular weight heparins. Could you reverse them with factor 7? Some studies show that it does create, it is able to reverse patients. The actual patient number in the last study that was published on this was 3 patients in humans. So I'm not going to be using a lot of factor 7 to reverse low molecular weight heparin. How many people have had the desire to reverse a low molecular weight heparin in your emergency department? Anybody? It's pretty rare. Occasionally something might happen where you need to, but not all the hands are going up. Like if I said, how many people have had to reverse Coumadin before? Yeah, pretty much everybody. Different animal. You could reverse it with PCCs and activated PCCs or FEBA. The studies say it works. Problem is that you probably don't have to do it. There is another drug out here that's an interesting problem. It is a synthetic indirect 10A inhibitor, and this is called, anyone know? This is Arixtra is the trade name. The other name is Fondaparinux. It's not Fondaparinux. It is not a French word. It's Fondaparinux. And this basically works via antithrombin to provide only anti-10 activity. Why do you care about this drug, and where will you hear about this? You'll hear about this in a patient who was on a low molecular weight heparin and developed HIT, heparin-induced thrombocytopenia, and somebody will suggest putting them on Arixtra as a reasonable choice in those cases. It is a reasonable choice. There are other ones also, but that is a reasonable choice to do because the crossover for HIT is virtually 0. So you will hear about people talking about that. If you were on this drug, you'd have to measure anti-10A activity because it only has effect on factor 10. What has reversed it? Some studies say that it's able to be reversed by factor 7. It probably also can be reversed with PCC and FEBA. Again, it's going to be a very rare time when you're going to need to do that. But in the back of your brain, realize they can be reversed, but you're going to have to force that system to work in order to fix that because that is a critical portion of your coagulation system that's being affected. What about the new kids on the block? How many people are old enough to remember the new kids on the block? Okay. So these are called NOACs, or novel oral anticoagulants. And these are the ones you've come to love as dabigatran, rivaroxaban, and apixaban, and soon to be edoxaban, and all sorts of other abans. And that's going to be coming, more of them will be coming to you soon because they seem to be pretty effective at doing what they're supposed to be doing. The first one out there was dabigatran. When it first came out, people always asked, is it dabigatran or dabigatran? So we called Boehringer Ingelheim and asked them, and they said, no, it's pronounced Pradaxa. I said, oh, okay. The correct pronunciation is dabigatran. So this does not require antithrombin to be present for it to work because these are direct thrombin inhibitors. They work by directly hitting binding sites on the thrombin itself to prevent it from becoming activated and functional. So the DTIs, you have dabigatran orally, you have argatroban, bivalirudin, and leparudin IV. How many people have ever given argatroban before for HIT? I've actually done that a couple times in my emergency department. That's a name that will come back to haunt you for HIT. It's probably okay to use something else instead of that in the near future. Like there's going to be approval for some of the anti-10A drugs because they are very rapid in onset, and you can use them as alternative anticoagulation in people who have HIT. You'll see that happening. So these are direct thrombin inhibitors. You can measure PTT But it's very difficult to correlate PTT with degree of anticoagulation in the same way as you would with heparin. However, you can say that if the PTT is not elevated, they probably are not taking their direct thrombin inhibitor. And if the PTT is very high, they probably have a significant effect. And the reversal of that number probably means that the drug is being reversed. But it's not quite as good of a correlation as you would see with heparin typically. So what about the direct 10A inhibitors, rivaroxaban and apixaban? These bind again without the need for antithrombin. And because they're anti-10 drugs, you measure anti-10A activity if you are on a need-to-know basis and you actually need to know that number. In real time, with new reversal agents that have a very rapid onset that could potentially immediately reverse these drugs, you might want to know what their anti-10A level is so you can make a good decision as to whether or not they need to be reversed with some of the new reversal agents. I'll come back to that in a minute here. So these present an interesting challenge for reversal because they affect you right here in the coagulation cascade, right at the terminal portions that, for which you can supply a lot of coagulation factors above there, but if you don't figure out a way to supplement the actual damaged coagulation portion of that system, you can't reverse them easily. Does that make sense? So this is actually kind of at a critical step in the process here. So according to the thrombostasis and the hemostasis and thrombosis meeting anticoagulation forum, and I bet that is a hell of a party to go to. Wow. These guys are the uber nerds of hematology. They made some recommendations, all of the new agents, which we will talk about notwithstanding, they made some recommendations as to what might be useful to reverse these agents. Because the first thing I hear, the residents go, oh, there's no way to reverse this. Or the other times go, oh, I hate rivaroxaban, there's no way to reverse it. Yeah, actually you can. It's just not pretty yet. It will be pretty, but it is not pretty at this point in time. So remember that dabigatran can be dialyzed. Think about that in someone who has a lot of bleeding. And the way to remember which one of these can be dialyzed is one of them starts with a D. D is for dialysis and for dabigatran. Rivaroxaban and apixaban are not well removed by dialysis process. So what about factor 7? What about PCC, 4-factor PCC? And what about activated PCC, aka FIBA? Well, factor 7 was inconsistent and not likely useful in dabigatran. 4-factor PCC showed some effectiveness, but plus minus. FIBA worked in the rats and rabbits and complete reversal in healthy volunteers and is likely the best option at this time according to the Hem-Onc Society, that we're probably going to see FIBA as our reversal agent pending the new reversal agent that was just released, if your hospital ends up getting that on formulary. We'll talk about that in a second here. Dosing of FIBA, we use 50 units per kilo in our protocol. So what about rivaroxaban and apixaban? Again, factor 7 did not work in animals. FIBA worked on markers in rats and rabbits, and it probably will work just fine in this circumstance. 4-factor PCC seemed to work very nicely because there was a decent amount of factor 10. And you notice that the factor 10 content of 4-factor PCC was much, much, much higher than the 3-factor content and a lot higher than FFP. So the current recommendation by the Hem-Onc Society is 4-factor PCC is the drug of choice for rivaroxaban and apixaban. Dosing of PCCs, 50 units per kilo up to 5,000 units is a reasonable number to think about. And you'll find this in various protocols if you look on the internet for various hospitals that have written their protocols for this. Specific agents for dabigatran, humanized monoclonal antibody fragments, Fab fragments. Idarosuzumab is the new one that's out right now, called Praxbind. That's the newest agent. And this just received a lot of press in the New England Journal of Medicine. And this is an interesting idea. This is a monoclonal antibody to the drug that will drop the levels of the drug out of your bloodstream in under a couple of minutes. And the antibodies are effective. We know antibodies are effective. We use them with, remember Digibind, giving Digibind or DigFab to somebody? And how quickly that would have effect. All of our anti-venin, those are antibodies. And we know that that stuff's effective. So, but there are the good, the bad, and the unknown. The good, it's going to work from the standpoint of taking the drug out of your system. The bad, imab, omab, and umab are all Latin for really freaking expensive. Just a fact of life. There is no such thing as a cheap monoclonal antibody yet. The unknown, does removal of dabigatran change clinical outcomes? We haven't seen enough studies to say, yeah, guess what? It stopped the bleeding, but the patient would have lived anyway. So we have to see those studies, but the problem that you're going to run into is, now that we have an antibody out there that's very effective at removing the drug, do you think for a second that your IRB is going to say, well, let's compare this that we know can reverse the drug to placebo in someone who's having significant bleeding. So you're not going to see that. You're going to see it compared to something else. So you're not going to get the answer to that question. But over time, you're going to get accumulated data that people are going to say, well, you know what? This person who had a ruptured AAA and they're bleeding like crazy, and we gave them the medication, the bleeding came under control immediately. You're going to start to see that stuff build up. But just remember, we can fix a number. We think we can fix clinical bleeding, but we don't know for sure. The next question is, when do you pull the trigger? If somebody just has a little bit of a nosebleed, I'm not going to spend $10,000 on a nosebleed. I might spend that money on a retroperitoneal hemorrhage, a ruptured AAA. Then again, if someone's on dabigatran, but they didn't take their dose for the last couple of days, their anti-2 activity might be low enough that I don't need to go to a reversal agent. So we've got an answer, but we still have to work on exactly how this is going to fit into our world. Does that make sense? So stay tuned. This is a fascinating targeted therapy that we've never had before, very specific. We've got to see where it's going. Specific reversal agents for anti-10A drugs, rivaroxaban, apixaban, and low molecular weight heparins. This is a recombinant, also Latin for very expensive, derivative, and this is andexanet alpha. And what it is it's a mutated or changed, chemically changed decoy factor 10. And what this thing does is it sits there and absorbs the factor 10 or the factor 10 inhibitors. There's the factor 10 inhibitors. These guys come into play here. And then they literally bind irreversibly, and then they're removed from circulation. And this is also another interesting solution to the problem. Throw in something that absorbs all the stuff that's there. And the interesting part is it's not specific. Anything that binds to factor 10, this potentially can work on. So all the newer drugs in that area, we'll have to see how that works. Effectiveness in phase 3, yeah, it dropped the levels very, very rapidly down and drop the 10A activity almost down to nothing immediately. It bounces back up again because you do stop the drip after a couple of hours, and it bounces back up again. You do see increased thrombin generation very rapidly with this drug too, which means you probably have a really good in vivo anticoagulation reversal effect. The same questions that you're going to run into with adarosuzumab, you're going to run into with this too. It's very effective at reversing anti-10A activity. It's recombinant, so it's not cheap. We don't know for sure if removal of these anti-10A drugs is going to change outcome, and we're not exactly sure when this needs to be used. Remember, like when you give rivaroxaban to somebody, you're giving it twice a day for if you're treating PE, you're giving it twice a day for a while, then just switching to a once-a-day regimen. If this person took the drug at 5 in the morning and it's 10 at night and they came in with their intracranial hemorrhage, do they need we don't know the cost of this, but we're going to say it's expensive. An expensive reversal agent in that particular individual. And that's when maybe knowing what is their anti-10 activity level in real time might help guide us. Wow, their anti-10 activity level is really high. They may have taken an additional dose, or it's early enough in the process here after the last dose where this might be indicated. Again, this is not something you give for a compressible bleed. This is something you give for somebody who is having a life-threatening hemorrhage, someone going to the operating room with an intracranial hemorrhage or a ruptured AAA, GI bleed, retroperitoneal hemorrhage, retropharyngeal hemorrhage, something bad like that. So that's where that gets considered. What about reversal of antiplatelet agents? How many people here have had your neurosurgeon say, give them platelets for their clopidogrel bleed? How many people have had him say that to do that for aspirin? Okay, so it is not crazy that could work. Let me show you where these drugs work. Your COX inhibitors, COX-2 inhibitors, inhibit this here and blocks your thromboxane A2, and that's aspirin. This is an irreversible binding, lasts until you make more thromboxane A2. NSAIDs, on the other hand, we don't worry about as much because their binding to thromboxane A2 and their inactivation is transient, temporary, goes away. So we don't have to worry about that all that much. The other ones that are out there, like clopidogrel, one of our favorite ones, I think someone calls it BleedX, that actually blocks the ADP-mediated activation of the 2B3A receptor, which we know of as part of our ability to cause platelet aggregation and platelet blockage. So can we overwhelm these things with platelets? Since aspirin lasts in the blood only 6 to 8 hours, if I give you a lot of platelets, even though some of your platelets are dead, let's just say the ones that are aspirin-bound are dead, I'm going to give you more platelets, and the half-life of aspirin is short, so I might sop up all the aspirin that's in your system. And then the additional platelets I'm going to give you might be effective. It's theoretically pretty good. Clopidogrel lasts about 24 hours, but there's some data to support its use. But the difference is, if your neurosurgeon says, give him some platelets, your answer to some platelets equals roughly 3 pools of platelets. What's a pool of platelets? It is either a single 6-pack, or if your hospital uses a 4-pack, it's a 4-pack, or a pheresis unit. All 3 of those things, a 6-pack, a 4-pack, and a pheresis unit, equal 1 pool of platelets. So you're going to give them 3 times the normal amount because you have to sop up all of the stuff that's there, and you have to give them additional platelets in order to be able to affect their ability to do primary hemostasis, which is the first part of this thing. Remember, with clopidogrel and all those antiplatelet drugs, if you were to measure bleeding time, which you won't because it's an antiquated concept, it would be elevated, but all of your coagulation parameters would be normal because coagulation has absolutely nothing to do with platelets. Coagulation is the other part of this cascade. What else could you possibly do to help these people? You could give them DDAVP, or desmopressin, and DDAVP elaborates von Willebrand's factor from your tissue. Von Willebrand's factor has 2 functions. Number 1, think of it as von Wildebeest instead of von Willebrand. The wildebeest has 2 big horns, right? One horn is the platelet horn. Von Willebrand's factor binds platelets to your endothelium. The other horn is the factor 8 horn, where it actually grabs factor 8 and carries it in the bloodstream. So you'll see 2 effects there. So this elaborates both factor 8 and von Willebrand's factor, which is going to recruit platelets that are the remaining good functioning platelets and help them to adhere. So when the neurosurgeons ask me to treat an intracranial hemorrhage, I'll do 2 to 3 pools of platelets. I'm not convinced it's going to change the outcome in that particular problem as much as it might in something where reversal of a bleed has a bigger impact on life expectancy, like in a AAA or something like that. And I do give them DDAVP in addition, if they're on clopidogrel. So I think it's reasonable, but if you're going to do it, you got to give enough for it to matter. And you have to decide, read the literature yourself and decide if the primary studies that were done in primates is enough to convince you. Okay, just a little bit about fibrinolytics, TPA, in any of its various forms. Let's look at a patient here who has an upper abdominal and chest pain with ST elevation in the inferior leads. They receive TPA because you're at an outside hospital and the duration of time it takes for you to get there is substantial. The patient then develops worsening abdominal pain and back pain with a drop in blood pressure, and you realize, oops, they also had a ruptured AAA, or they had a ruptured AAA and that was the cause of their pain to begin with. Now you're in a weird situation here. How am I going to fix this problem? Well, I would suggest that you can resort to prayer if you're so inclined, because that might be a good choice. That might be better than placebo in this circumstance. So there are other things you could possibly do. It's not just that's the only possibility. Fibrinolysis, especially with TPA, works like this. You have plasminogen. TPA activates plasminogen to plasmin. Plasmin takes cross-linked fibrin and turns it into one of our favorite molecules in the world called the D-dimer. And fibrinogen becomes fibrinogen degradation products. Why? I tell my residents this all the time. D-dimers are useful, and this is where D-dimer becomes, this is where it comes from, cross-linked fibrin. So this is an active clot. When you're breaking it down, if you have a lot of clot, you produce more D-dimer. And if you cross some imaginary threshold, it makes it more likely or less likely that you have a thrombus someplace. So just be careful that you do not inappropriately order a D-dimer on somebody, because you know what happens. You order a D-dimer on somebody, it's accidentally positive, then they get a CT scan, and then they get contrast nephropathy, and then they get a transplant, and they sue you, you lose your license, you go to jail, and then you lose your entire family, and it's all because you ordered a D-dimer. So just choose wisely. That's all I got to say. I believe in it, but don't do it as a screening test, because that's the worst way in the world to use that. Okay, so how do the antifibrinolytics act, like Amicar? Epsilon aminocaproic acid. They reversibly block plasminogen and prevent the entire breakdown to plasmin, so you cannot lyse clots. It is literally a reversal agent. And Amicar has been around forever. The only place I bet you will have heard of it, except maybe that 1 or 2 sentences in Rosen and 1 or 2 sentences in Tintinelli, is you may have heard of it if you've had hemophiliacs who have dental bleeding, because they give them a swish and spit solution of the stuff, and that is effective sometimes in causing thrombosis around the dental bleeding. And in addition, it can be given orally for the same effect. It can be given IV in TPA-related bleeds too. Interestingly, There is not a ton of data for these being used for reversal in cases where people have been given TPA for an MI or a PE. It's been reported in bleeding after TPA from a subarachnoid hemorrhage that has been looked at. And remember, let's go back one here. The way this works here, this same process is affected by tranexamic acid. Just substitute the word amicar or epsilon aminocaproic acid for tranexamic acid, and it works in the exact same way here. So when you heard about, we talked about the crash trials and all the use of tranexamic acid, what you're doing is you're inhibiting the ability to break down blood clots. So what about cryoprecipitate? If you are given TPA and you are rapidly lysing your clots, you're going to need more substrate in order to help reverse it. And people will talk about giving cryoprecipitate because cryoprecipitate has enough fibrinogen to be useful. The dose is typically 2 pools or about 10 bags of cryoprecipitate in somebody who has got TPA-related bleeding. So we talked a lot about different choices here. We talked about the good, the bad, and the unknown. We talked about inappropriate thrombogenic risk versus bleeding to death, balancing the coagulation system in the wrong direction. We've got a lot of decisions to make. Some may be obvious, like caution water on road during rain. Some may be less obvious to understand. And some will be extremely complicated, for which you're not going to figure them out until you have more data to help guide you through the decision-making process. And there may not be a right answer for a while. So when I'm confused and I don't know what to do, and I really have no idea, I ask myself a very important question. WWJD, what would Jerry Hoffman do? Jerry Hoffman would say, well, you might be reversing a factor 10A level or reversing a PTT or an INR or something like that, but are you making a difference in clinical outcome and making differences that matter when you're using an expensive reversal agent? And that is a good question you ask yourself. And I'm not saying that I'm just saying choose wisely, learn about these things, and figure out what your institution has and how to use it. If you don't have a protocol, write one. If you don't want to write one, you can email me and I'll send you the version that we have at Ohio State. It will be changing probably because I'm going to guess for sure we're going to end up with adairosuzumab in our formulary and also probably andexanet alpha because of the popularity of these other anticoagulants. And remember, the reversal agents are going to drive that fear away. Well, I can't give these apixaban and rivaroxaban and dabigatran because I don't have a reversal agent. That's going to go away now. So you're going to start to see an increase in the number of complications. Keep that in mind. Final answer, PCCs and APCCs, APCC is FIBA, they work well on warfarin. Probably PCCs are the drugs of choice. Factor 7 does not work on warfarin bleeding. Low molecular heparin is partially reversed by protamine and probably by some of these other agents, but protamine is probably our drug of choice if you ever need to do anything. Fondaparinux can be variably reversed by factor 7 inhibitor or factor 7 agents. Rivaroxaban and apixaban may be somewhat reversed by PCCs, but probably the 4-factor PCC is the one that you're really looking for. Kcentra, that's the one we have in the United States. No definite proof. Dabigatran may be somewhat reversed by activated PCC or FIBA. No definite proof. Antiplatelet agents may be somewhat reversed by platelets and DDAVP. No definitive proof yet. New antidotes will be out there for the NOACs in the very near future, coming to the door at your hospital, knocking with their expensive knockers. Probably should have phrased that differently, but worked for me. Coagulation and anticoagulation are delicately balanced, so be careful when you start messing with the system. Use them in the right system, and primum non nocere. Do no harm. Thank you.